Good afternoon, everyone. My name is Dr. Eric Toring. I'm the Senior Vice President for the American College of Veterinary Preventive Medicine, and I want to welcome you on behalf of the ACVPM and our partner organizations, the National Association of Federal Veterinarians, the American Association of Food Safety and Public Health Veterinarians, and our new partner in the CE webinar series, the National Association of State Public Health Veterinarians. So with that, I'm going to go ahead and introduce our guest speaker today. Dr. Jonathan Lustgarten is the Senior Biomedical Informatics Specialist and Product Manager for Mars Veterinary Health. He is responsible for the artificial intelligence and machine learning for the PIMS and EMR that will serve all Mars hospitals. He is also responsible for developing and curating the structured master data behind the system. He helped architect the code catalog and ordering systems for the ground up to allow future integrations. Before Mars Veterinary Health, Dr. Lustgarten was the Director of Veterinary Informatics for Compassion First Pet Hospitals. He has served as a medical director of a hybrid veterinary hospital, and before that, he completed a veterinary business fellowship. Dr. Lustgarten has over 25 papers and 14 first author papers, including Veterinary Informatics, Forging the Future Between Veterinary Medicine, Human Medicine, and One Health Initiatives in the Journal of the American Medical Informatics Association, Open. So with that, I will turn it over to our speaker today, Dr. Jonathan Lustgarten.
Good evening. Hope everyone's doing well. Hope everyone's warm on the East Coast. It's pretty cold here. So today we'll talk about veterinary informatics, the why, the how, and when and who, and pretty much all the other questions I could possibly ask, and hopefully spark some continued conversation at the end of the talk. So, standard conflict of interest. I am currently an employee of Mars Veterinary Health, as you heard, but all the opinions here represent my own. I've not been sponsored, and I do not have any financial disclosures for any company mentioned in this talk. I will bring up some, excuse me, I will bring up some companies and what they're doing, and some of the advanced tools and techniques they're using, but it's not an endorsement. It is a relaying of the state of veterinary medicine as it is today. So, some of you may have said, what is veterinary informatics? The formal definition, which is still not very formal given that a lot of people make up their own, is the use of computer science, data science, and information technology to impact veterinary medicine. Clinical veterinary informatics, which you may have heard from various papers, is the application of this technology and technique to apply the clinical setting to improve workflows, efficiencies, and outcomes, and specifically clinical outcomes. Other types of medically based informatics include biomedical informatics, bioinformatics, clinical informatics, medical informatics, and so on. There are, I think, somewhere in the range of 25, 30. And so these informatics cover the gambit, and a lot of them are focused on human medicine. We don't really have a veterinary radiology informatics per se. A lot of techniques there could be applied to veterinary medicine anyway, but there's not a lot of veterinary specific. So veterinary informatics kind of covers the gambit. There are also non-medical informatics. There's library informatics and a few others out there. So what are the components of informatics, particularly veterinary? So this is adapted from one of the papers in 2022. We have biology, veterinary medicine, and this is a translational research component. You have computer science and biology that kind of intersect bioinformatics. It's a little bit fuzzy, but it's a definition. In the center of all of it would be biomedical informatics. And then veterinary medicine and computer science is the intersection of veterinary informatics. Now for another definition for clinical informatics by Dr. Dennis is you have all these different components: computer science, data science, information technology, social and behavioral science. And clinical veterinary informatics is that little tiny space that's right in the center. And so if you think about the application of clinical veterinary informatics, if you take computer science and veterinary medicine and then add in all these different components, it's very hard. So what makes up informatics? Like, why are we using this term? We hear data science, we hear business intelligence. What are the differences? So I start with what I call the pyramid of information. So first at the bottom, you have the raw data. That can be either specifically a printout from a computer, could be ones and zeros, whatever raw data is in, not processed, not enhanced, whatever. Then you have a contextual meaning. So what are the specific data fields of importance? So when I look at a giant database or an Excel spreadsheet, or even a long list of analytes on a chemistry, what are the important or contextually meaningful analytes to what I'm looking for? And the results are, what are the important elements out of these meaningful analytes? What are the important results? Oftentimes people call that analytics. Then information is understanding, well, are these results, even though it may be important for this query or for the diagnostic, is it contextualized? Do I really understand why it's doing that? And then the useful information, what I call actionable information, is really the top of the pyramid. It's when I can take that. And useful information, as well as just the one level below of information, is usually what goes into knowledge. So this is traditional. So just to be clear, I'm not saying people in data science only do these three. But when you talk about data science, usually you mean manipulating the raw data, finding the contextually meaningful data fields, and exporting the results or applying results from it. Traditional business intelligence doesn't necessarily deal with the raw data transformations, but handles the contextual meaning and generating results. So what am I, the KPIs and all that stuff, generating that, figuring out how to present that as a report or an interactive visualization or whatever. Advanced business intelligence, which is a newer term, that's degrees are now being offered in this, is can I take those results and make it into information? So using filtering of just because it's significant doesn't mean it's informative. And then informatics tends to be the top three period part of the pyramid, and even the top two. It's dealing with the information. How do I get from analytics or results to information? Then how do I get from information to useful information? So kind of a summary of information. It's the ability to take data from the domain of interest and get it all the way through to some form of information that can be acted on, even if the action is, well, I need to do more research. The part of it, what I didn't show in that pyramid, is being able to understand the biases of all those different steps, as well as the generation function. What is the source of the data? So a great example is for how many people have looked at the practice management system. For some reason, there's lots of Affin pinchers. Why? Because it's the first dog breed usually in their list. So you have a natural bias just because of the way the system was built for there to be Affin pinchers in the veterinary PIMS. And without understanding that bias, without understanding that part of the information, you get a lot of spurious results that look good, but you haven't taken into account the original biases. And that key component is really hard to visualize. It's really hard to explain. You have to kind of be part of the domain, or at least part of understanding about how the information is entered into the system to really understand that. And that's where an informaticist is so key. So who are these experts? Some people may be surprised. I say every single veterinarian in the world. They might not realize it or know how to extrapolate to like many cases at a time, but every veterinarian is an informatician. All clinical staff members who can recognize that information or whatever presented to them may not make sense or correspond to the clinical picture they see. People have training in modeling interactions or progression within veterinary medicine. And those, obviously, who have been trained to do all the above. So, why do I say that? Well, let's take an example. A veterinarian has to intake a lot of data. Chemistry, CBC, UA, culture vitals, all the fun things you see in a regular day of practice. You also have clinical decision support tools, Merck manuals, references, you go on and on and on, textbooks, 5-minute consults, etc. Then they have to figure out which out of all those numerous reams of information is contextually relevant to my case that I'm seeing that's right in front of me. Sometimes I have to go back and say, hey, I thought I remembered something, go back in the records and retrieve it. I have to do some more data extraction or find more relevant fields. And sometimes I have to make an assumption because, well, if emergency vet and the client doesn't have prior records and the general practice that referred them is closed and you can't get the records, you now have to start making some extrapolation. Now I have to analyze all the above, extract the data, the relevant components, make it into some sort of presentation and turn it into information, usually through a medical note, right? That's kind of a report, particularly the patient history and when you're writing your SOAP. And then I have to take what I've written and develop kind of a working diagnosis list and then or a problem list, and then figure out what are my treatments, what is my plan. Now, as I've been leading everybody, this awfully sounds like this. And that's why I say every single veterinarian practices this in the world. And some may skip over fields, some may say, oh, they do it internally, but all these different steps are just, you may do 2, 3 steps at the same time, but every veterinarian goes through this process. And same with any clinical practitioner or anyone else that may be involved in the process of intaking information and generating some sort of useful information from it or actionable information. So now hopefully I've convinced a lot of you that veterinary informatics is for everyone and a lot of people practice it. What are some key activities? Understanding the data generated by the clinic or by a study or by any other generation function that you would like to use in machine learning or do analysis on or analytics or statistics. It doesn't always have to be a computer program or AI program. Understanding the workflow and how to integrate new information. So if I have a new product, how does integrating a new product or a new tool, a new service into the system, how does that impact the workflow? How does it impact new information? What is do we become an Ouroboros and start eating our own tail? This is very important clinical veterinary informatics. In fact, most of the medical informatics degrees being issued, particularly in masters, tend to be in this clinical area, at least in human medicine. Now, there are a lot of medical informatics or biomedical informatics or bioinformatics degrees being issued for other areas, but in terms of true total numbers, clinical informatics tends to be the highest number. Evaluating accuracy and impact of tools and software in clinics. In human medicine, you have whole departments of informaticians dedicated to impact analysis, workflow analysis, medical analysis, all that. In veterinary medicine, it's someone's job to figure out, well, if I install the software, is this going to impact our medical qualities? Is it going to impact any of our things? And oftentimes we have to leave it to some of the vendors to prove to us. But in larger clinics, they have people who look at it saying, what is the operational impact? What is the medical quality impact? Understanding the biases. I cannot say this enough. One of the key part of a veterinary informatician is understanding the biases, because those kill a lot of projects. A lot of money spent in human medicine re-engineering or retrofitting algorithms or analyses or adjusted for it specifically due to the biases, because a lot of them are not understood at that time. So someone says, this data is acting weird. Why is it acting weird? And you have to go investigate. In veterinary medicine, if we had a veterinary informatician, they could understand that process early on. Developing an implementation plan based on the data, models. And so all this stuff, I'm personally biased towards models because I generate a lot of them, but developing models that help predict or analyze or even suggest or recommend. And in the age of generative AI, models that generate new text for you to use. I would just remember, none of this implies that you are actually doing the coding. Many informaticians wind up doing some coding or can code, but that is not a requirement. There are also many medical informaticians, particularly in the human space, that do not do any coding, but they understand how to develop models, what is the technology, what is the information behind it. So is this different from other disciplines, right? I talk about veterinary informaticians and other informaticists as its own discipline, as it's different from epidemiology, it's different from public health, it's different from biostatistics. In terms of the end goal, no. We're trying to produce useful information or useful models so that people can affect something positively, right? We hopefully not negatively, which can happen, but the end goal is the same. The key to veterinary informatics is using data as the primary source first, as opposed to just maybe generating a model and then comparing. Slightly different to computational biology and a lot of the computational sciences will generate models based on known entities, generate data, and then see if it matches reality. And that actually is very common for sparse data. That was very, very common for many, many years. It's actually a better way because you don't have millions of data points to be able to split evenly into test and training sets. Now in the age of data, that's not a problem. So informaticians can iterate and can actually test on wholly naive data sets very quickly. So this is a personal bias of mine coming from my training and my background. I believe all disciplines that work in the information area will use, is particularly in veterinary medicine, will use veterinary informatics. And all veterinary informaticians at some point practice something in a different discipline. That doesn't mean we always fully overlap, but I've done my susceptibility models a couple times. I've used population life curves. I've done all those statistics and all those modeling techniques at some point in my career, even though that is not a purely veterinary informatics technique. This means training someone in veterinary informatics involves understanding appreciation for all these other disciplines. And I think that's where human medicine has some opportunities as well, is when you are trained in biomedical informatics, a lot of times they don't require you to take other courses in epidemiology, public health, and all these other disciplines that are well-established, well-respected, but they could learn a lot because, transfer learning is a big part of information, right? You take information from one area and go to another. And since veterinary informatics is really kind of foundational phase, there are not that many people who are trained in informatics that are veterinarians, and not a lot of them are trained in actually the tools and techniques of how to apply it to veterinary medicine. And so since there's foundation, being able to transfer learn, being able to use these techniques in different areas is crucial to growing the veterinary informatics discipline. So today's world, right? I just spent about 15, 20 minutes talking about veterinary informatics and how everyone does it, and it's what is part of it. So why do we need to know that? So new technology, often powered by AI, as we're seeing, is developed rapidly. So LM, neural networks, augmented reality, analytics, advanced biomaterials, genomic therapy, particularly personalized medicine. We're seeing a lot of CAR therapies. We're seeing a lot of personal genomics for cancer treatments. We're seeing all these things. And this new technology is developed very rapidly. You will see it not there, and the next day it will be there. Or within a month or two, you'll hear an announcement and they'll come to market. Particularly in veterinary medicine, we'll go over some companies, but there's been released more new AI technology released in the past 2 years than in the prior 15. The application in veterinary medicine, not just in the clinics, is rapidly evolving, and people are taking tools and techniques from all these other disciplines, from human medicine, from motion, from physics, and applying it to veterinary medicine. Now, it may not be a veterinarian applying it, which is not good or bad, but understanding, having someone knowledgeable about being able to turn whatever the output of that algorithm or that tool is into something useful for us to use is critical. In human medicine, it took years for this to be part of the standard. And when I show you a timeline, there's some nuclear winter, some AI winters. We call it the nuclear winter because AI just stopped development for a while. There's some AI winters in there because people were not interested. People didn't know how to use these tools, or there was nervousness. And even now, there's still not enough medical informaticists or biomedical informaticists out there to fill all the needs for all this rapidly AI evolving tools that are being deployed everywhere. And one thing I'm passionate about is don't repeat other people's mistakes. And AI in human medicine is progressing so fast and has so many things figured out that why not use their findings and their failures to inform our progress? Why do we have to make the mistakes that human medicine made? Now, that doesn't mean that because they made a mistake, we can't do better. But we should learn, and we should really know and really understand. So when I talked about the AI winter or the nuclear winter, so particularly starting around the 70s when computing resources became really more available, between 70s and like the late 80s, beginning of 90s, there was a lot of computer use. There's stuff at the NIH, eMycin. I know some of the creators actually gave my first lecture in informatics that I took when I was at Pitt. And they talked about expert-based rule systems. Some of the best initial machine learning AI programs were done because they basically took Dr. Jack, who knew about antibiotics and knew about bacterial infections, and took all the information he knew and put it into a rule system. That was the first AI, but it could be disseminated to everyone. And then people started realizing, like, around 1988, 89, like, wait, how do we do this in clinics? Who's going to be able to understand the data and the biases? How are we going to handle this? Now, for those that may not know, CASNet was used for glaucoma decision-making, particularly focusing on like when to treat with glaucoma and not. Mycin was bacterial infections, and DXplane, which is down here at the bottom. Let me go over here, right here. That was one of the first computer decision support systems built out of University of Massachusetts. And its first function was to generate differentials. And people were like, well, is this going to take away the doctor's job? Is this going to take away other things? So a lot of people put a pause because computer technology was advancing so rapidly, people were worried about the quality of the medicine. And there wasn't a lot of people trained in how do I understand it. Around 2000 with deep learning and late thousands, things started picking up again, particularly when you started talking about CAD, which is a um, type of information system. You have obviously you have the Amazon Alexa, Amazon Assistants, Google Assistants, etc. You also have a lot of decision support tools for radiology being involved. That was a whole example of how not to release AI, because when they first did it, they present, look, the AI can find things for you. What they discovered is that that's not a good way to gain acceptance from clinicians, because it became like, what? So you're not going to come to me, you're going to go to a computer? And we know that, computers make mistakes. You hear today about hallucinations. And so there's a lot of things we can learn about deployment of AI in medicine that's been discovered already, at least how not to do it. The Ben Franklin quote, I learned how not to make, sorry, Thomas Edison, how I learned how not to make a light bulb. And so these are the types of things that we can really improve on if we take the prior examples. But there's also things we can avoid. We can iterate a lot faster being in veterinary medicine, given the impact of our tools and how we can integrate it. Though our software needs a little bit of work. So what about veterinary medicine? I just mentioned all about human medicine. Well, here are some AI products that have been released in the past couple of years. These are all within a 5-10, and a lot of them have been releasing new products sooner. Those that have been in wearables. Wearables have been around for about 5 to 10 years. The past 3 years have seen a massive explosion in number of wearables, and almost all of them inform a detection system, right or wrong, but it still has AI produced models in there to say, is your dog getting up? Is there a change? Is there some sort of signal to noise ratio that tells that the dog's doing something different? So how are they producing it? These companies usually take data scientists, machine learning, and expert panels, so veterinarians that they hire or recruit. And if they're lucky, they find people trained in epidemiology, public health, or veterinary informatics, and are veterinarians. Most of the time, though, since there's not that many of us, they usually just use panel or group think to try to solve it. Now, that works out very well because veterinarians are quite adept at taking in information and transforming it. But there's a lot of back and forth, and it takes a lot longer than it would be had there been a person who understood informatics, not necessarily a veterinary informatician, someone who understands informatics as part of the guiding product. So what about those that are implementing these systems? All the doctors and clinics, all the different research studies, all these different individuals that have to take these new tools that have been developed and implement them. Well, often little to no time, often little to no training in technology. And that doesn't mean everyone, but a lot of the places, particularly when you go into clinical veterinary informatics, a lot of them are not taught about the AI models or bias or any of these other technologies. They're given a lot of fancy UI, but understanding behind the scenes is very important to practicing good quality medicine. And they're also not able to assess, was the model trained on the information I use? So a lot of times people say, oh, I can go into your clinic, and they have a big issue. In fact, radiology informatics is all about transforming these models. And for a long time, because of the way that models were built and things like that, they actually could not take a model trained in one hospital and bring it to another. And that's because of data drift. And this means that the type of images, the rate they see, the exposure, the algorithm, the techniques, whatever they have, was different enough that the data being sent into the algorithm in hospital B was different than hospital A. And so if you think about these larger conglomerates, how are they going to handle it? How are these things going to work? So let's take some examples. So these are examples that I personally have done and implemented, particularly the first three and the last one we are building at this point. But these were tough. These were a lot tougher than I expected because of those questions and because specifically the implementation part. So appointment reasons from appointment notes. If most of you, and a lot of this is focused on clinical, but there's applications particularly the last one, to any sort of object in veterinary medicine. So in clinics, there's appointment reasons. You have appointments that are, you write out long notes, and then you may have a system that allows you to tag it, saying this is a sick visit, this is a whatever visit. This is duplicate annotation. The note should reflect the reason, or at least a summary of the reason. And in theory, sometimes in some appointments it's blank, sometimes it's purely just numerics like, hey, deposit owed, whatever. But looking at some of the large data sets that I have, 90+% have important information about the visit contained within. So for clinical staff, the note, unless the system forces you to pick a reason and it's the only way you can get things scheduled, the note often is more important than the structured reason. Why are they here? Because you'll get like why the patient called and why the client called and why the patient's coming in today. For operational informatics team, the structured reason is much, much, much more important than the note, because up until the past couple of years, natural language processing and the tools and techniques in AI has not been available enough or robust enough to be able to extract it. Now, if I'm going to design a system recognize reasons from notes, right, to eliminate that duplicativeness. So something like this: I write smelly ears and patient with urinary outside the box. So I wanted to tag that there's an ear problem and a urination problem. How would I do that? What are the data challenges? So first off, how people write. Sorry, excuse me. What are the data challenges? Those are data challenges that are sorry, excuse me. What are the data challenges? The data challenges are how people write, what they are going to write. Are they going to use abbreviations that are standard? Well, veterinary medicine doesn't really have a UMLS standard note annotation. They use clinic specific, or even personnel specific, or doctor specific. Then how do you standardize it? And then operationally, great. We have these add reasons options. How do you fix that? So if you were to build a system, what would you expect the results, right? We have to remember, we not only have to figure out the data problems and all those things, we have to figure out the expected results. We want the average number of valid reasons to be increased, right? A lot of these systems have an average of just a little bit over 1. Sometimes they have less than 1 if they're not required. And that's because people just want to pick the top one and have it, work out. The next one is decreased time to booking from before implementation. So if I'm going to add this AI, I don't want to make it longer. I don't want to make the CSR do more work or the technician do more work and be slower, right? We already have to keep up with all these digital, the online appointments, the message appointments, the people rescheduling. You have to do all these things. Slowing them down at the front desk could really choke a clinic in terms of its operational. We also want to increase the value of the information. Can we, if I see an ear problem, urination problem, as a doctor, I can walk in, as opposed to having to read the notes and say, okay, what are they trying to say? And in certain clinics, people stop reading the notes because it's slower, and they just say, so what are you here for today? Because especially when those systems don't require reasons, or you just have to pick one, they'll pick one. So if they just pick urination problem, you may miss the ear. If just pick the ear, you may miss the urination. So the next one, patient history, problems, and diagnosis. The taking of history, particularly patient history, can be done prior to a clinician entering the room. Sometimes it's not from an online form, sometimes it's from a technician, sometimes it's from CSR, but sometimes from the doctor itself. It offers a chance to set up a problem diagnosis list as well as encode them, if your system allows you to, for use later. Again, this is another duplicative annotation step, because in most veterinary systems we have, and even human systems, I have to write everything into one area and then synthesize, think about all the problems, and then remember to go to a different area of the system and add it. Even if the areas are right next to it, I have to take my look from one area, transfer to the other, and remember to type in all the different things. Now, the likelihood, these problems can be complex, especially if you're in a specialty clinic. They can be, really hard to remember to enter everything into your problem list or a diagnosis list. Now, doctors tend to write it maybe on the sheet in front of them, like I do, before I had a more structured system. But again, it's duplicative. Why do I have to write it and then have to rewrite it again in whatever form? So what if I had a system that can extract problems and diagnoses from a text and suggest it to the clinical staff member? Now, there's some protocols in there that you have to be careful of, that you have to think about. There's some issues, but what are the data challenges? So obviously patient history, again, source. Is it coming from the client? Is it coming from the technician? Is it coming from the receptionist? Is it coming from the doctor? Is it coming from a referral doctor down the road? Is it coming from another GP from a new practice? Because they didn't have time. Is it coming from urgent care? All these types of biases that you get can cause the data to look different. Then how do we detect it? Is there a standard that we're using? Now, in my cases, I used SNOMED. Living in the US has one of its advantages is that you can use it, but the SNOMED is international, so any place that subscribes to it has a really good standard terminology. And the Veterinary Terminology Services Laboratory down in Virginia Tech does a really good job at updating it for veterinary medicine. And Dr. Green is fantastic to work with. If you have questions about it, or you want to talk about it later, please don't hesitate to raise you to talk to me afterwards. But they're great at adding new terms, at translation. We've worked with them to get Spanish and Italian translated. But all these things, you need a structured system so that you can say these type of words represent that. And what are the operational challenges? Well, I'm using AI or machine learning to suggest terms and really doing term detection. It's not really suggestion of diagnoses. So it's not like doing synthesis of like syndromes and things like that in this case. But what does it mean? How is the doctor going to use it? How's the doctor going to look at it? How's the doctor, is it going to impact the medical part of it? What are the medical challenges? Well, if your detection system is not accurate enough, it's going to miss things, which is better than nothing, I guess, that it's missing, but also may suggest things that are not right. So do you really, in the ideal world, you could have the system automatically add it to your problems list and diagnosis. But as we saw from early on in human medicine, that leads to resistance, the perception of power. Dr. Krista Bartos from Pitt had a fantastic paper about implementing an EMR in clinics, and the perception of power is key to success. I highly recommend you read that. And it really helped shape me on my understanding of how power and autonomy really play to influence and adoption of these type of AI tools. And so these medical challenges are pretty significant, because if you start auto-inserting and you're wrong, you could lead people down a wrong track. You now have medical record entry. So we opted for a different approach, and I'll show you in a second, where we bring it up to individuals and they can choose to click on it or not, but it's always right where they are. They don't have to go to another screen. They don't have to go anywhere else. So what would be the expected results? Increased tagging annotation of medical record. This was not being done previously in large quantities because mainly our software didn't allow it. But even if it did allow it, it was often hard. It's a separate screen. I had to go all over the place to find it. I get to use this now, information, to pre-fill other areas. So if I know the patient's coming in for limping, I can make sure that my orthopedic section of my physical exam has more elements in it. If I identify it as food allergy, I can talk about what diet trials, what exposure, what do we know what allergens are focused. If I'm talking about inappropriate urination or decrease in appetite, I can talk about what they ate. If they talk about vomiting, we can go down different streams, and that brings it up. So I don't have to go search and start typing additional sections. If you build it together, these are things that are now possible because I've annotated. And one of the key points about this is what I call temporal relevancy. That is, I'm entering the information in a temporally relevant fashion, such that I'm not trying to reverse engineer or retrofit whatever I write, which is what most notes are and what most systems have today. And so this is really, really important. But what a question for maybe later for discussion is, what part of the medical record or ordering system do you think we can improve? You have problems list. Imagine if we had it for a physical exam too. What could we help with our ordering list? What other opportunities? And I'll talk about my personal thing. I would love, because these Antec, IDEX, all these diagnostic laboratories have such complicated panels, and with all these different analyte combinations, I would love, based on my physical exam prior findings, to be able to say, okay, I want to make sure I track these 5, 6, 7, 8, 9 analytes. This isn't going to say, hey, it's kidney. Are you making sure you're tracking these commonly won by, say, iris? And then have the system automatically find the panels when I search for it, saying, hey, these cover your analytes of interest. That's a dream of mine at some point in the future. But this is what it may look like. I can say people type in these sections in general history, and I found all these different points. One important point is that you see some people wrote inappetence. Decrease in appetite is the official SNOMED term, but inappetence is obviously inappetence is a synonym. And so this allows you to quickly find, I can click on this button, add it to my problems list, or add it to my, if there was a diagnosis here in my general history, for example, I could add it to it. And so this is what it could look like. What about diagnosis detection from diagnostic laboratories? This was my first project that I did when I was in vet school. I worked on something like this during my degree, and I'm now able to actually implement it in practice, which is pretty cool. So all the different lab results, particularly report-based lab results, have two parts to it. I have to find the pertinent to the clinician and the case. So when I mean pertinent, it's the clinician's perspective, not what the person wrote its perspective. I just want to make sure it's clear, because all the stuff in the report, the people writing it want to make sure it's pertinent to the case. And then I have to record or encode those results. What are the important findings? What are the important diagnoses? What are the important problems? Whatever. What are the rules? What are the procedures I'm recommended to do from this case? Into a differential list, or into my medical note at least. And, again, I had to read this whole thing, usually they mention specific terms, diagnoses in it. I have to take that and I can use Control C, but then I have to go find another screen or another tab or open up another document and copy it in. So why don't we develop a system that can auto-highlight and simplify the input? So what are the data challenges? Unlike before, where patient history and appointment reason have high levels of variability, our clinical pathologists and our gross pathologists and histopathologists while the format of the report, they tend to use similar languages, and the type of diagnoses you get from a lot of these, while specific and often complex, tend to fall in certain categories. They also tend to be formatted generally similarly. They have similar types of formats where they talk about the substance, they talk about the findings they have, their interpretations, or the microscopic findings, and then the commentary. Now, there may be some, when you have multiple slides or multiple tissue samples, there may be some interdigitation in the report and whatever, but they tend to be pretty standard. So we don't have the data challenge of high variability in structure. But what we do have is a high variability in the terms of definitive versus possible, or my differential list. And as we know, for a lot of the cytology reports, you're not often, other than like some of the lymphoma, mast cell tumor, stuff like that, you're often getting a list of possibles, not a list of definitives, which is part of the fare with the samples. So how do I, as a clinician, read through this giant list of text, find those likely versus possible differentials, and find it for me? I mean, that can be hard, particularly because you could say my possible differentials include, or you specify your diseases and say are of the possible differentials, right? To us, we can read it forward, backward, and fine. To computer, it's very complex. What are the operational challenges? When do you read it? How do you read it? How do you verify that you're not missing something? How do you verify that you found the most important parts? How do you bring it up to the users and integrate it into your system such that the users don't have to do duplicate annotation? Because again, the point of the system is that most doctors have to do it entry at least twice, if not more than that, depending on how their system's set up. What about the medical challenges? Now, in this case, since you're detecting the diagnostic diseases or diagnoses or problems or findings, it's slightly different than your current ones. But how do I annotate it? What if I am led down the wrong path? That is no different than anything else. But again, we don't want to necessarily insert it into the document or have the AI make the diagnosis, because again, it's wrong, and it's we're in the new area, and those that have decided to throw GPT or any of the other large language models, they have a hallucination rate of about 20% or more on these types of samples, because these are very medical, very specific. And let's be honest, OpenAI, Google, things like that, even Microsoft, are not training on millions of cytologies to learn patterns. So assuming that we solve a lot of these challenges, and if you think of any during this talk or anything like that, please add more questions to the Q&A. Our expected results would be hopefully increased direct annotation results. So I can tag that cytology with a diagnosis. I can decrease transcription time because I'm having the system highlight. In this case, an unintended consequence, which, operationally, medically, you have to wonder, it actually allows you to find the areas that are mentioning that diagnosis, either where likely or possible. And then I can say, what is, read the text around it. So it's almost like a summarization or like a putting a sticky note in a different area. So those are some of the key points in it. And this is what it could look like. Clinician, you have random results, and you have your ordering health concerns, and you can find your diagnostic. So for natural language querying for patient records, just as a quick definition, those that may not have heard that term before, natural language querying is the process of a user writes a query instead of having to worry about the stars, the quotes, the slashes, the ands, the ors, or whatever. Can write it in a normal sentence, and the system understands what you're trying to say and pulls the relevant information. So how can we enable users to find the best matching records to the query? Allow users to not have to write out every antibiotic or every type of dermal orthopedic surgery. Right? There's a lot of them. B, in our systems, if you were to try that, you have to remember how it was encoded in your code catalog or in your medical record, whatever you wrote. So what are the data challenges? This is a hard one. I have to teach the system what antibiotic means. I have to teach the system what dermal and orthopedic surgery mean. And this is actually one that we're looking to finish pretty soon. And what we found is that structured information, as well as even the language models now that have been built, actually have a decent relevancy, but they have to be trained on medical information. So things in the public health area, the PubMed area. And they can kind of help you guess what it is, and then have the user refine it. So instead of user typing out all the different antibiotics, trying to remember, you can have it pre-populate with a set of items and then solve it. Operational usage, I think everyone can understand, like, how do I present the results? How do I make sure it's fast enough? I don't want to hit enter, go grab a cup of coffee and come back like it used to. And what is the medical research impact? This is pretty significant. And I think this is one where this is probably the next big advance in search across the world, is the semantic type searching that is being powered now by these language models is going to be so much more powerful that the way we search, how we search, the understanding of what we're looking for is going to improve significantly. And if we can do that in medicine with the complexity, like if I want to search for vomiting, hematemesis, right? All these other things that may not have a synonym explicitly defined, we have now hierarchies and we have now structured things. The system now that it understands these things are related to it. So it can search down a whole tree to find everything you wanted about vomiting, even if you didn't specify that you want acute versus chronic versus, old blood in it, as a grainy coffee look or whatever. So how do we avoid the Zig's human estimate and avoid the winters? Because that's a really key point. The first part is veterinarians have to be part of the AI process. I cannot stress this enough. Without veterinarians part of the AI process, we're going to get to a lot of people coming up with products searching for a problem. And obviously, as part of the process, then you understand how the data and how it was recorded or generated. Because a lot of times people look at the data and assume it's there. They'll look at an entire medical record and say, oh, I can build all this information. But they don't realize that 80% of the information is done after the patient's already left. So I can't build a tool for that because that information is not going to be there when I run it. That has happened, and I've helped a couple companies avoid that. Understand the algorithm biases. So understand how you're getting into it. Does not mean you know how to code or create it. Doesn't mean you can put it together yourself, but you should understand some of the techniques, some of the bits of information behind it. Understand, for me as a clinician, understanding and researcher, understanding the impact the AI has on the workflow and outcomes is paramount. A lot of times people say, oh, it's going to be cool, but they don't understand, how do I know that the AI is helping? I gave a lecture previously on what's called the Veterinary Informatics Risk Assessment Score, or VERA. That will help people categorize their risk, understand what they have to do, have a score, and I can share with you that information later. It's really helped me, particularly in the projects I do, try to assess what is the riskiness of the AI I'm doing, and how do I either mitigate it, or how do I change the AI so I don't have such high risk in certain scenarios. Enforce standards on systems. So a lot of people, we talk about it, and a lot of these systems say, I can do a standard. But if it's so hard to use for the busy practice, the standard being there is not really helpful. So how do we enforce the standards on the system, but make sure it is done in a way that it can improve quality? work together, start at the clinic level and work towards AI tools. Instead of having a tool to find and try to shoehorn it into a problem, start with the problems that we're trying to improve the efficiencies and work towards AI. Recognize that many of us already do veterinary informatics without formal training. And imagine what we could do if we had a whole team of trained veterinarians or trained staff members that could do it. So in summary, you do not need to be trained in veterinary informatics to practice it. The training could be helpful for effectiveness and efficiency. You don't have to reinvent the wheel because you can learn from others. Understanding the source of data, particularly biases, and this is my personal thing, is key to impacting utilization and implementation. There are real problems that can be solved and improved today using these tools, as you see. And I have a backlog. I have probably about 15 or 20 other algorithms to improve efficiency, just to have the clinic have less stress in doing their day-to-day. And all of it's built around the central concept of autonomy of the clinical associate. We should avoid the mistakes of past, and opportunity to have all the veterinarians and clinical staff members be taught informatics like they do in human medicine. Every MD that graduates, I think DOs now too, have to go through an informatics course. There's a requirement for graduation. Yeah, I think everyone should go through an EPI course, a public health course, a statistics course, and an informatics course, but I'm biased because I like that stuff, and maybe a lot of veterinarians don't. So, but I think they should be exposed to that as a requirement in order for them to understand the new world that they're living in, because without that, it's going to be very hard. So I want to make sure I say thank you to ACVPM for having me. It's been an absolute honor to present to everybody. The Association for Veterinary Informatics, AV Informatics, they're the ones who sponsored me and selected me to talk. If you haven't heard of us, please go to our website. I could talk more about it. It's an organization of a bunch of us who like veterinary informatics and want to help veterinary informatics become more standardized and more deployed to help all the things I've talked about today. Mars Veterinary Health for letting me present on the work I'm doing, and you guys for your time. I know there's a lot of you here. I really appreciate it on a day. Any questions, don't hesitate to ask.
All right. Well, thank you, Jonathan. This is Dr. Turing again. So with that, I think there are a couple questions here. The first question and a couple of questions specifically ask if you can provide an example, Dr. Lustgarten, of what is AI hallucination?
Hallucination specifically refers to generative AI. So without generative AI, it's just called the AI made a mistake. So hallucination is the fact that generative AI, large language models, ChatGPT, I think it's called Gemini now, Claude, all these large language models from all these companies, you ask it a question and it just starts making things up or misinterprets or doesn't understand. And so these hallucinations are, can be hard to detect. Sometimes it's funny, right? Sometimes you get a hallucination. There's a case recently where a chatbot hallucinated and allowed a user try to have someone get a car for $1. And in Canada, there actually was a chatbot hallucination that now they are forced to pay, the airline's forced to pay for, because the chatbot gave them wrong instructions. So it's basically the making up or replacing or accidentally saying the wrong word fundamentally or writing the wrong word than what your question was or what the intent was or what the data behind the scenes. And I didn't want to go too deep into it, but these language models are based on probability distribution. In one of my talks I gave at VMX, we talked about, if I say the cat in the blank and you fill it in, there's a whole list of words that you might say. A lot of people say hat. But if I'm talking about a cat in the shelter, what about a cat in the carrier? All depends upon context. If the AI system doesn't understand the context, particular LM, or forgets the context, gets lost, as some people will call it, it will fill it in with whatever the most likely next word is, which in a lot of our areas, particularly in medicine and veterinary medicine, is even worse, could be any random thing, 0.000001% probability of 10,000 words. And the jitter of these language models, they are non-deterministic, which means you ask the question to the machine twice, you will not get the same answer. They'll just randomly pick a word, and so we'll just fill it in. And that's a huge issue. And so there's techniques and tools, stuff like that, but all of them is about mitigating, not eliminating hallucination. So all those LLMs and things like that, these language models, the OpenAI type stuff, all have this risk. And it's really bad in veterinary medicine. Some people say 1 in 10. If you were to do just ask a question or analyze it, you can get like 1 in 5. And that's a large number. And like some of these hallucinations could be wrong, like calling an adenoma an adenosarcoma, right? Or adenocarcinoma, right? And I've seen both. And adenosarcoma, you're like, what? And so these things have come out of the machine, even though you're talking about an adenoma, and that can lead to a whole different medical diagnosis, approaches, everything. And that's a problem. And that's why hallucination for these things need to be controlled and, can be mitigated, but it's still there. That's why I think I saw from one of the comments, what it can do is due to common things, and you can tune it, but you could do common things very well to help allow the user or the clinical staff to do things that really require their brain, and not as hard for a machine to do.
All right. Another question. With more practices moving to a corporate model, what do you suggest as safeguards to prevent AI being used as an efficiency and profit tool at the expense of patient and client care?
So why does it have to be either or? Right. So good medicine is good business. I mean, that's the fundamentals. Now, it's one of the things I think is important is having veterinarians, people who are on this call, trained in understanding the difference, understanding how these tools could be implemented, directing those tools. A lot of the time, these are coming to the companies that are pitched for these, I have this hammer, I'll make everything a nail. And some of the veterinarians, they're not even told about it. They're not even integrated. The medical officers may not fully understand or may not be trained. And so whatever the companies are saying, impact. I think there is always going to be a trade-off whenever there's money involved, but they're not mutually exclusive. I think you can have a system used for more profit, more money, while also improving clinical care, clinical outcomes. Imagine AI, let's take a mythical AI that eliminated the likelihood of overestimates. How about a magical AI that, decreased the time to follow-up and increase the adherence to care? Well, all three of those things would increase the profit, increase efficiency, decrease adverse events, and increase quality of care. So we can come up with these things. But I think if you're driving to a point, how do we make sure these companies, particularly the larger companies, pick the right AI that can do these things and not try to sacrifice one for the other? And that's part of what my talk is about, is getting us involved in the informatics of it and understanding it and having our companies and teams understand the impact of these decisions. But a lot of times they'll say, oh, I do ABC, but they don't understand the downstream impacts because, well, you need someone who understands the technology, how it's implemented, and then the clinic. And so I think if you, to turn the question around, we can improve the use and selection of the tools by having people more knowledgeable and be there for that, for those decisions and be involved. But without people who can understand this bigger picture, that the transition from raw data all the way to useful and actionable information, it's going to be a lot harder because people will make decisions the best they can for whatever reason and not have either the countering or the direction of the clinical staff member who understands the impact and can help drive it towards a better outcome for all the above.
Question regarding training in informatics. Is training in informatics available to perhaps integrated into any veterinary school curricula at this point?
No, I've been asking. I've gotten a couple, there are a couple of places down, I think University of Georgia, I want to say, has a kind of expansive program in the last year, I believe, of veterinary school, where they talk a little bit about it, but fundamentally, it's not really there. Now, as I said, a lot of people, in epidemiology, public health, biostatistics do informatics type things, but there hasn't been a formal program. People in Association of Veterinary Informatics have been talking about that and trying to get it, but it's hard getting traction when there's so many things fighting for it. And I really think there is a large amount of people out there who want to do. I get calls and emails and talk to people regularly who are interested. I just the veterinary schools, kind of like human medicine. There's so much on their plate. How a horizontal priority queue, how do you measure it? I'm hoping in the next couple of years we start seeing more and more courses. At least start with courses, if not whole disciplines and masters and PhDs. Let's start with courses first. And if you all know people that are interested in schools or different parts of the country, I'm more than happy to talk about it. I know there's lots of people at AVI that would be happy to talk about it to get more and more people trained, because we need as many people, like the people who belong to this college, to help guide where we're going because we're on a train that's going lightning fast.
There's a comment in the chat about the Human Preventive Medicine Board certification offering a subspecialty within informatics. The American Board of Preventive Medicine um, is offering a subspecialty in informatics. And that was posted by someone that I believe uh, is involved in informatics. She's the Associate Director of Informatics for the Division of Healthcare Quality Promotion at the CDC. So there are other veterinarians definitely involved in the subject matter area.
And American College of Pathology, the human pathology, actually has a pathology informatics fellowship specifically for that. So there are human colleges, and as you see, Human Preventive Medicine Board certification. There are human colleges that do offer specialties thing there, but I'm hoping people will gain appreciation and start inquiring more and kind of push us towards that because we've seen in human medicine when there aren't enough people to make those decisions who are knowledgeable about it, it can take a long time to undo or change courses to something that helps everybody. So we've seen it before. So I'm hoping we can avoid it because, well, we're veterinarians, so we should be able to.
Excellent. Well, I'm going to close this out today. We've reached our hour. Dr. Lustgarten, you're receiving a lot of positive comments in the chat. I don't know if you're watching the chat, but a lot of thanks and a lot of kudos to an excellent presentation, a great talk. So I'd like to echo that on behalf of the American College of Veterinary Preventive Medicine and our partner organizations. We appreciate your time, appreciate your expertise, and just general thank you for taking the time out of your day to spend an hour with us and provide the talk. We're going to do this again, not with Dr. Lustgarten, but with other speakers. I want to remind everybody that we're always looking for speakers. The ACVPM does this about once a month, and we can't do it without volunteers like Dr. Lustgarten. So if you're interested, you can email me at admin@acvpm.org, and I will get your presentation or your proposal to the Continuing Education Committee. So
Thank you.
thanks, everybody. Have a wonderful day, and